Shalom, sisters of Israel. Welcome to Fruitful Possession. My name is Sister Jemima of the House of Jacob. Today's class will cover time to give birth. This is for educational purposes only. We are not affiliated with any other organization. Please consult with your doctor or midwife. Thank you. But before we get started with today's lesson, I'd like to share some scriptures with you. Let's go to the book of 2 Esdras, chapter 16, verse 38. And it reads, As when a woman with child in the 9th month bringeth forth her son with 2 or 3 hours of her birth, great pains compass her womb, which pains when the child cometh forth, they slack not a moment. 2 Esdras, chapter 8, verses 8 and 9. And it reads, But that which keepeth and is kept shall both be preserved, and when the time cometh, the womb preserved delivereth up the things that grew in it. For thou hast commanded out of the parts of the body, that is to say, out of the breast milk to be given, which is the fruit of the breast. So all praises. This actually goes over how the baby develops inside the mother's womb, and also it first refers to breastfeeding as well. Let's go on to 2 Esdras chapter 8, verse 11, and it reads, That the thing which is fashioned may be nourished for a time, till thou dispositest it to thy mercy. So that is another scripture that refers to breastfeeding. And you're more than welcome to go over any of these scriptures on your own in the 1611 King James Version Bible. Dad, Mom, and Baby Series. Time to give birth. Whether you decide on a home birth, a birth center, or a hospital setting, this class today may help you with your decision-making process. As today's lesson progresses, we're going to focus on C-sections and identifying breech positions in pregnancy and how it's dealt with in the maternity world. We're also going to talk about fetal positioning. So let's go on to the next slide here. And I want to share this scripture with you. This is a really good scripture that you may find very helpful. It says, 1 Timothy 2, verse 15, Notwithstanding, she shall be saved in childbearing, if they continue in faith and charity and holiness with sobriety. Common terms in maternity care. Vaginal birth. Vaginal birth means the birth of a child through the vaginal canal. A natural birth is known as the birth of a child without any medication. Vaginal birth after C-section, which is also known as a VBAC, refers to a vaginal birth of a child with a previous history of C-section. A scheduled or an unplanned C-section is a surgical procedure to remove the baby. So whether the mother has planned for the C-section or it happens unexpectedly, it is known as a surgical procedure to remove the baby. Parity. This is the number of pregnancies, 20 weeks or greater. Gravida, a pregnant woman. Prima gravida, a woman pregnant for the first time. She has no history of ever getting pregnant before. Multigravida, a woman who's been pregnant more than once. Nulligravida, a woman that has never been pregnant or has birthed a stillborn. So now that we've gone over some common terms and we talked about a normal vaginal birth, a natural birth, C-section, types of C-sections, whether they're scheduled or unplanned, let's talk about the different types of C-sections in general, because there's several different types. The type of C-section scar that you have can also affect your ability to have a VBAC, which we discussed earlier, which is a vaginal birth after C-section. So it depends on what type of C-section you have. That can determine if you are an eligible candidate for a VBAC. So let's talk about the transverse C-section, because that's the most common type that women get when they opt for a C-section. It's the most common type, and this surgical procedure is, their approach is, the cut is made from side to side across the low part of the uterus. So you can see through the illustration, through the first picture, that is a low transverse C-section. Another option for a C-section could be the low vertical. As you can see, this was the low transverse, and this is a low vertical. It says the low vertical up and down cut across the lower part of the uterus. So as you can see, this is how they would actually make the surgical incision here. And this is considered major surgery. Whatever procedure you have, this is considered major surgery. So this is the low transverse one. That's the most common one that most people do, most women do. And then the second one is low vertical, where the doctor would make an incision up and down, cut across the lower part of the uterus. And then there's another one called the high vertical. So the high vertical is once the standard for C-section. So this used to be the routine one. This one used to be the forerunner instead of the transverse. It says once the standard for cesareans, this up and down, cut across the upper part of the uterus is now considered risky and typically only performed for extremely preterm deliveries. It says the most common type in the early 1900s, still used sometimes when a rapid C-section is required or for premature breech or transverse babies. So sometimes you may see this in different countries. You may see this in certain circumstances as well. So as you can see, there's other approaches as well. But the most common type is the transverse. Statistics. Let's go over how statistics plays a role in maternity care and its outcomes by collecting data and analyzing it. So as you can see by some of the statistics information gathered in this chart, which focuses on the primary reasons for C-section delivery, we're going to talk about preeclampsia, which is a woman who is diagnosed with a form of high blood pressure in pregnancy. She was not diagnosed with high blood pressure or hypertension prior to getting pregnant, but during her pregnancy, she developed preeclampsia. And as you can see, the reasoning behind, the primary reasons behind a C-section delivery is 3% of it is because of preeclampsia reasons. 34% of the reason why C-sections are performed is because labor is not progressing the way the doctor feels it should be. Or 4% is because of a large baby. 17% is because of a breech baby. That's when a baby is not in the optimal position. And 5% is because of a high-risk pregnancy. It could be because the mother is over 35 years old. She may have an underlying medical condition. For example, she may have diabetes, or she may be pregnant with multiples, and she may be older. It could be also because of the mother's request. That's 3% of the reason, whether it was a planned C-section where she had opted to not deliver vaginally and she scheduled a C-section, or it's just that things weren't going the way she wanted it to go, or she couldn't tolerate the level of pain from the labor, or for some other reason, and the mother requested. Then also multiple babies. So 7% is because the mother may be pregnant with twins or multiples. And then 23% is a concern over the fetal heart rate. So you may hear bradycardia or tachycardia. Bradycardia is when the heart is beating really low, and tachycardia is when the heart is beating very high. So as you can see, the most common reasons are labor not progressing, 34%, concern over the fetal heart rate is 23%, and 17% of it is because of a breech baby. The baby was not in the right position and they weren't able to get the baby to go in the optimal position. And we're going to go over fetal positionings a little later. The C-section rate in the United States has gradually increased over the last 20 years. In 1989, the percentage of C-sections was 22%. And then there was a dip in 1996 to 20%. However, as time went on, the percentage of C-sections was as high as 33% in 2009, capping off at 32% in 2019. It says, what can we learn from this graph? After a steady decline in the early 1990s, cesarean rates increased rapidly from 1996 to 2009. Since 2009, the rate has plateaued. There are side effects of electing a C-section. Some include an infection at the surgical site, blood loss, blood clots in the legs, pelvic organs, or in the lungs, injury to the bowel or bladder from the procedure, reaction to medications or to the anesthesia that is used during the process, and it can also impact future pregnancies, how many pregnancies you can actually have based on the number of C-sections. Between 1989 and 2019, there is a variety of data collected to show that there are several different types of midwives attending different types of births. As you can see from the legend, from 1989 to 2019, 1.3% of those vaginal births were attended by other forms of midwives, whether they were a certified professional midwife, direct entry midwife, licensed midwife. Between 1989 and 2019, there was a gradual increase of certified nurse midwives attending all types of births. So as you can see, in 1989, there was roughly about 3% of certified nurse midwives that were attending all types of births. And then by the time 2019 came, 9.8% of certified nurse midwives attended all births. Between 1989 and 2019, 14.4% of certified nurse midwives were attending vaginal births. This is a significant difference. Although these are not very high numbers, there was an increase from 3% of certified nurse midwives in 1989 to 9.8%, and there was about 4 or 5% in 1989 that attended vaginal births, but by the time 2019 arrived, there was 14.4% of certified nurse midwives attending vaginal births. However, between 1989 and 2019, there was 1.3% of other forms of midwives attending vaginal births. Let's take a look at this video. This is a home birth of a young couple who opted for a water birth at home. So although you can decide on a home birth or delivering your baby at a birth center or hospital, the luxury of having a home birth is beneficial. You can decide if you want to have a water birth, which they have, and the water is very warm. And as you can see, she's doing very good with her labor. She's actually smiling going through her process. She has the father there, and he's very supportive. And you see, he's just checking to see if the baby's head is coming out. They're doing great teamwork to help the baby come out. So as you can see, the baby's head is coming. And the water is pretty warm. This is a great temperature for the baby to come out. And the baby, even though the baby's head is coming out and it'll be submerged in water, the baby doesn't take its first breath for like the first minute or two. So she's just doing great. She's practicing her breathing, and she's got her support team there. The midwife is very close, even though you don't see her there. She's close by. And the mother's just feeling for the head of the baby just to make sure the baby's coming out. She feels pressure. You see, she's just going through her contractions and her labor. And when she gets an urge, she'll push. You see, the baby's coming out. It can happen very quickly, especially after giving birth to more than one child. You see, look how lively the baby is. You wouldn't see this in a C-section or if a mother was sedated. But as you can see, this baby is very alert. Look at the eye contact with the mother. And he can hear the father. Look how lively he is. And she's doing well holding her son. So they went on to birth out a baby son. And look how alert he is. They did a great job of teamwork. Please feel free to pause the video, take a break, and reflect back on some PowerPoint slides that you thought were helpful in helping you to make your decision where to give birth. So when a midwife performs an examination on mom during pregnancy, she's going to use several different maneuver techniques. During the first maneuver, she's going to want to know what is the presenting part. And the second maneuver, she's going to want to find out where is the back of the baby. And then what is the fundus? Where is it located? And where is the cephalic prominence? And each maneuver has its own special technique. In the first maneuver, which is what is the presenting part of the baby, the midwife will actually try to grasp the lower uterine segment between her thumb and her fingers of one hand to feel the presenting part. So she's going to take her thumb and her fingers at the lower uterine segment to feel the presenting part. Where is the head? The other hand may be placed on the fundus, which is at the top, to steady the uterus. This maneuver should be performed first, since the head of the baby is the part of the fetus that can be identified with the most certainty because it's round, and since it is at or in the pelvis in 90% of the cases, the logical thing is to first look for that, to look for the presenting part, for the head, and where it's located. So once the midwife is able to establish where the baby's head is, she thinks about two important facts. Is it longitudinal? And that the presentation is cephalic. So usually there's an attempt to move the head from side to side to see whether it is outside the pelvis and free, like if it's floating, or is the baby's head in the pelvis and it's fixed. So that's what she's looking for in the first phase, which is the presenting part. During the second maneuver, she's trying to find out where is the baby's back. Now that she's able to find out where the presenting part is, where is the baby's back at? And then the third maneuver is, what is the fundus? So usually the midwife will move her hands up the sides of the uterus, and the fundus is palpated, which means she just takes her hands and she's feeling, her hands and her fingers, she's feeling on the mom's belly to find out where the fundus is. She's going all the way up to see how many weeks. She's actually dating the baby too. She's pretty much measuring the length of, where the fundus is to see how old the baby is. Is it 13 centimeters, for example? That means the babies are approximately 13 weeks. Is it 10 centimeters when she measures with her tape from below, like where the pelvis is, the lower pelvis is, up into the fundus, just depending on how far along the pregnancy is. So then the last one is the fourth maneuver. And in the fourth maneuver, where is the cephalic prominence? So basically, the midwife would take her fingers and kind of gently move them down on the sides of the uterus toward the pubic area. And the cephalic prominence is felt on the side where there is greater resistance to the descent of the fingers into the pelvis. In addition, it is noted whether the head is free. She's trying to determine if the head is free when she's looking for the cephalic prominence. Is it floating, or is it fixed, or is it engaged? So those are some of the type of things she's looking for. She's also trying to listen for the health of the fetus by listening to the heartbeat. So once she's able to auscultate or listen to the fetal heart rate, she wants to know if she's hearing fetal heart tones, are they normal? Is the heart rate between 120 to 160 beats per minute, which is a normal heart rate for a baby inside a mother's womb. And once the baby's born, it starts to slowly, gradually go down over time. But inside the mother's womb, normally, the fetal heart rate is between 120 and 160. So anything below 120 is considered bradycardia or slow fetal heart tones. And anything above 160 is considered tachycardia, fast beats. So it says the fetal heart becomes slower at the height of uterine contraction. So when a mother is actually going through contractions, the fetal heart rate is actually starting to slow down. But then it'll speed up again after the contraction was worn off. So if she's in labor, it starts to go down when a contraction comes, but then it speeds back up after the contraction is over. So when we hear about like a slow heart rate for a baby, a slow rate has a greater significance than a rapid one, which means the rhythm is regular and of a tick-tock quality. Irregularity is a sign of fetal embarrassment. Stages of labor. Did you know that there's 4 stages of labor? The first stage is the onset of labor to full dilation of the cervix, which is 10 centimeters. And prima gravadas, which are mothers who are pregnant for the first time, it can last up until between 6 and 18 hours. However, in multipara, where the mother has been pregnant several times, the first stage can last between 2 and 10 hours. The second stage focuses on complete dilation of the cervix to the birth of the baby. This stage can last between 30 minutes and 3 hours in first-time moms and between 5 and 30 minutes in multipara. The third stage will deal with the birth of the baby through delivery of the placenta. This process can last between 5 and 30 minutes. The fourth stage focuses on stabilization of mother after giving birth to baby and the placenta. It focuses on stabilizing the patient after she's given birth to her baby and to the placenta. So remember, there's 4 stages: first stage, second stage, third stage, and the fourth stage. And the first stage is the longest process. It could be between 6 and 18 hours for new moms and between 2 and 10 hours for mothers who have been pregnant before. What is the difference between true labor and false labor? That's a good question. True labor is when pain comes in regular patterns versus when false labor comes, labor pains are irregular. In true labor, patterns will shorten gradually. However, in false labor, there's no changes. If pain begins in your back and moves to the front, it's true labor. However, if the pain is in the front, most of the time is localized to one area, it's false labor. So in true labor, duration and intensity of labor will increase over time, but in false labor, there are no changes. In true labor, you will have a bloody show. It may be present, but there will be no bloody show in a false labor under normal circumstances. In true labor, the cervix is effaced and dilated. The cervix was able to thin out and widen, but there's no changes in the cervix during false labor. In true labor, the cervix, the descent of the baby is the presenting part. But in false labor, the baby's head remains free. So in true labor, there's a descent of the presenting part going down, but the baby's head remains free during false labor. In true labor, when the mother is experiencing labor pains, sedation has no effect on stopping true labor. However, in false labor, with adequate sedatives, it will stop false labor or some other method. What will trigger the onset of labor? Well, that's a good question too. First, lightening has to occur between 2 to 3 weeks before reaching full term. So the mother feels the baby settling into the lower uterine segment. And prima gravadas, which is a mother who, this is her first pregnancy, engagement will take place 2 to 3 weeks before reaching full term. She'll also experience secretions within the vaginal canal, and it'll begin to increase over time. She may also experience weight loss because her body is releasing water. The mucus plug is released during this period and discharged from the cervix. She will also experience a bloody show. The cervix begins to thin out and widen. And she will also experience backaches, which are present. During this period, false labor pains are irregular. So let's talk about what is effacement and dilation during labor. So as you can see by this illustration, it's showing that the baby's in the right position, the baby's head is face down. And this right here you'll see is a mucus plug. A mucus plug is used to prevent bacteria that enters the vaginal canal from getting to the baby. So you'll see the mucus plug is here. This is the cervix right here. And this is the vaginal canal. As you can see that is effaced, the vaginal canal has widened. The cervix has thinned out. So that's called effacement when it thins out. And when it widens, it's called dilation. So during most of the pregnancy, the cervix uteri is about 2.5 centimeters in length and is also closed. But toward the end of that period of gestational progress changes, the movement from a posterior to an anterior position in the vagina begins. So ideally, without going into too much detail, ideally the cervix should be ripe at the onset of labor. So what they're really looking for is for it to be totally dilated to 10 centimeters. That's optimal for the baby to be birthed. So ideally the cervix should be ripe at the onset of labor, because a ripe cervix is one that is soft and then it's less than 1.3 centimeters in length. So when the cervix is ripe, what does that mean? It's a good sign that the uterus is ready to begin labor. When these conditions are present, sometimes induction of labor is feasible. So during labor, the cervix begins to shorten further and further, and then dilation begins as well. So once the os is open enough, which is 10 centimeters, that allows for the baby to passage through. The fetal head will be able to come through, and it means it's fully dilated. Let's take a look at this video.
New Pensacola mom unable to celebrate the birth of her daughter due to a medical mishap. Now she says she's stuck in limbo. She spoke exclusively to Channel 3's Hannah McKenzie about her experience.
It's unlike anything I've heard of before, and I'm not alone. Turns out doctors in our area were also stumped when a patient's epidural became stuck in her back. A routine medical procedure gone horribly wrong. Hey there, Selena, it's Hannah.
Hey.
How are you feeling?
Tired and drained and sore.
FaceTiming us from her hospital bed, Selena Gray has had an epidural lodged in her back since June 25th. Talk to me about the pain that you're in right now. On a scale of 1 to 10, where would you say you're at?
I would say I'm past the 10 probably. That it's excruciating pain.
Gray went into labor at Sacred Heart Hospital in Pensacola. At 7 pounds 3 ounces, Serenity made her debut a day later on June 26th. But perhaps the most memorable moment in this new mother's life, tainted by what happened after she gave birth.
Basically, my epidural looped itself into my spine. It's in a knot in my spine, and they've been trying to tug at it and and I haven't been able to really get up or move or do anything.
Feeling helpless, Gray checked herself out of Sacred Heart and transferred to Baptist Hospital a few miles away. Doctors there hesitant to even touch her.
They just keep telling me in all my years, I haven't seen nothing like this. So basically they're just as shocked as I am.
Now she's heading to Gainesville, to University of Florida Health Shands Hospital. How long are they saying that's going to take?
6 hours, so I have to be on my side for 6 hours.
In the back of an ambulance?
Yes, ma'am.
And once she gets there, she's not even sure what to expect. With numbness already in her legs, she tells me she's not thinking about the worst case scenario, paralysis. She's just focused on getting help and getting home to her new bundle of joy.
She's so cute and just alert. She has her big brown eyes open. She's the best. She really can just make you so happy, and I just want to be home with her.
I've asked Gray to keep me updated on her status. Right now, she is in an ambulance on her way to Gainesville. I was unable to speak with a doctor there, but I did get a hold of representatives from Sacred Heart and Baptist hospitals, both of whom declined to comment. Hannah McKenzie, Channel 3 News.
Let's talk about positioning of the baby when it comes to giving birth. Why do mothers prefer giving birth in the upright or vertical position? The vertical or upright positions refer to giving birth standing or sitting or squatting, and upright kneeling. In these positions, it helps to create about 30% more intra-abdominal pressure in the vertical position. So this helps the mother to get more power in pushing that baby out. Her son or her daughter, she's able to push the baby out with more force. In this position, it also reduces the length of labor, fewer complications, lower risk for forceps deliveries, and less needs for anesthesia. It also enlarges the pelvic outlet, and the mom is enabled to use her explosive forces to the greatest advantage. Let's take a look at these three pictures. One where the mother would be standing or squatting, or she may be on all fours kneeling on a chair or a birth ball, or laying flat on her back. How do these three positions impact birth? It says here's mom is standing. So in this picture, the mother is standing when she's in labor and she's going to give birth. It says you can see that for a baby, it's a right angle turn and straight on down to reach the outside world. So this is great for gravity. The mother's standing, or she may be squatting in this position. The baby is easily able to come down and be birthed out in normal circumstances. Even in this picture, where if the mother was on all fours on her knees, this would be a great position as well. It says, if I tilt the picture to represent mom on hands and knees, kneeling in a pool or kneeling while leaning on a chair or birth ball, the same results happen this way as in the first picture. But however, it says when the mom is laying on her back in this flat position, but if I rotate the picture to represent a mother on her back, all of a sudden she has to push her baby up and incline and against gravity in order to give birth. By default, this has to be the most exhausting position. So she's just giving an illustration of two possible different positions that the mothers would prefer giving birth to a baby at a better position with gravity. But this one will be difficult. And since the mother's laying on her back, she may also be prone to perineal tears as she's pushing the baby out, because she is laying on her buttocks trying to push the baby out. But if she's in these positions, she's reducing her chances of perineal tears or lacerations. Let's go over this illustration of the different types of presentations that you may find during a mother's pregnancy. This is a normal presentation where the baby's head is down, is in the right position, is optimal for giving birth. There are 4 common types of breech presentations. 3 of them are present in this one. The first one is a breech complete, which is where the flexion at thighs and knees are present. So the flexion at the thighs and the knees are present. The buttocks is the presenting part. In the frank breech, flexion is at the thighs, but the extension is at the knees. This is the most common type, accounting for almost 2/3 of all breech presentations. The Footlink Breach can be either single or double, with extension at the thighs and knees. The foot is the presenting part. There is another breech presentation known as the nailing position, where there's a single or a double with extension at the thighs, flexion at the knees. The knee is actually the presenting part. These are some other abnormal presentations during this time when you're trying to give birth. This is either the shoulder or transverse, with the baby's on its side. So either the shoulder will be the presenting part for giving birth, or the baby's completely transverse. Or the baby is face down, but the face or the brow is the presenting part. What are some of the contributing factors to this occurring? Why do we see these varieties and causes for breech presentation? That's a good question. Some contributing factors could be prematurity of the baby, or an excess of amniotic fluid, or even multiple pregnancies where the mother is pregnant with twins or multiples, as well as several other factors. Please feel free to pause the video, take a break, and reflect back on some PowerPoint slides that you thought were helpful in helping you to make your decision where to give birth. What are some of the benefits of using a birth stool? Some benefits include space in the mother's pelvis can increase by as much as 28 to 30%. Her contractions are more effective with progressing in her labor and delivery. She is less likely to need medical care when using a birth stool. There's a 54% less likely for a baby to be distressed. Labors are shorter. Less than 30% chance of C-section when using a birth stool. There is a 21% reduction in episiotomy tears. And it's less likely that the mother will need an epidural using a birth stool. Now let's take a look at this next video on how moms can move the baby out of a breech position by techniques of inversion.
The forward-leaning inversion activity is one of the most important ones you're going to do during your pregnancy. Have a chair or a bed that you can kneel on, and then walk your hands down so that your body is inverted. It's helpful to have a partner handy to hold on to your calves and your ankles to help support your body. When you're finished with your third breath, you're going to walk your hands back so that you can sit back down on your heels. If you have your partner handy, allow them to help you back up. Once you're comfortable doing the forward-leaning inversion, this is an advanced version of the technique. Walk yourself down on your hands and then prop yourself up on your forearms and elbows. This allows for a steeper, deeper stretch of the ligaments inside your pelvis. Again, it's important to have a partner nearby to help support your calves and ankles during this activity. Come up off your elbows, walk yourself back on your hands, and then rest back on your calves.
So this is a list of items needed for a home birth setting. Some of the supplies include between 2 and 6 washcloths, 6 to 12 receiving blankets for the baby, lead-free water hose and indoor inflatable pool if you're going to sit in there for comfort measures, a water pump, indoor inflatable pool, a pool liner, bottle of grapeseed or olive oil and chapstick, cloth diapers, cloth adult diapers, long cloth sanitation napkins, heating pad and plastic sheeting, thermometer, large chuck pads, nipple cream, newborn baby caps, garbage bags for soil, laundry, or trash, a flashlight, a crock pot, a home birth kit. You also want to prepare 2 weeks or more of meals for you and your family. You want to consider and learn more about a birth doula or a birth sister. She will help you during the labor process, and there's another type that's helpful with the postpartum period immediately after giving birth. And you may also want to bring some other supplies as well. So let's take a look at this video on a home birth.
As hospitals around the United States deal with the coronavirus crisis, the fear of infection, drug shortages, and strict rules imposed on visitors are now leading more and more women in the United States to consider home births. Expecting mothers must also but weigh in the issues involved. One of the biggest roadblocks, of course, is the cost factor. According to estimates, home births in the U.S. could cost up to $4,000. The largest amount as a part of the process is when it comes to the midwives' fees. Home births are also mostly not covered under the U.S. health insurance nexus. Many hospitals around the country have implemented new anti-infection rules that limit the number of people in the delivery room. In New York, hospitals had barred husbands or partners from being a part of the process or from being in the delivery rooms. This was until the governor, Andrew Cuomo, stepped in and signed a decree stating that no woman had to give birth alone. Let's talk about expecting a mother, Ashley, who is pregnant for the 3rd time after 2 miscarriages. A birth at home, she says, is the only option for her.
Definitely anxiety's up, and that's another part of it, of like why I'm like a bit hesitant to go to a hospital, just because that's where they're taking people, you know, like people are going to be in and out of there. And also, like, I also think about whether or not I would be taking up any resources from, you know what I mean, like these nurses, like I don't know if they work in like multiple areas of the hospital or if they just do it, so they couldn't really promise that like my husband definitely would be able to be there. So that was a little bit like, I was like, oh my gosh, like, because with everything that we had been through, that was like not an option for him to not be there. You know, we've worked our butts off to like get to this point. So I just didn't want to take that chance. So I did talk to a friend who had 2 home births.
Even as expecting mothers consider birth at homes, midwives are struggling to cope up with the sudden boom in terms of the demand for their expertise in home births. Of roughly 12,000 certified midwives in America, only an estimated 3,000 practice outside hospitals. Midwives have also changed the way they work in order to prevent the spread of the infection. This includes cutting down on house calls, seeing patients via online tools, and means of video conferencing. In the pre-coronavirus world, only 1% of births in the U.S. took place at home, but most experts believe that the percentage may go up this year. Even as health services reel under the crisis, the American College of Gynecologists maintains that hospitals remain safe to give birth.
Ecclesiasticus chapter 26 verses 20 and 21. When thou hast gotten a fruitful possession through all the field, sow it with thine own seed, trusting in the goodness of thy stock. So thy race which thou leavest shall be magnified, having the confidence of their good descent. I hope you enjoyed this presentation today. I like to say all praises to the Most High. Most High and Christ blessed. Shalom.